Hi, my name is Ananya Kumar and I am a junior in bioengineering. This summer, I worked at the Positron Emission Tomography Center on a case study with Dr. Amy Luat. This is the case study of a 3-year-old female with Jacobsen syndrome. Jacobsen syndrome is an inherited disorder that is secondary to partial deletion of chromosome 11q. Jacobsen syndrome presents with growth and psychomotor retardation, characteristic facial dysmorphism, and either thrombocytopenia or pancytopenia. Some patients may have multisystem anomalies. Its neurological signs and symptoms vary, but speech and motor delay as well as cognitive impairment are invariably present. Our patient was a 3-year-old female born at 35 weeks of gestation to a 28-year-old G2 P1 mother by vaginal delivery with a birth weight of 2.1 kilograms. Her prenatal course was complicated by polyhydramnios. At birth, her APGAR scores were 6 and 8. Her postnatal course was complicated by respiratory distress, congenital heart disease, hematologic abnormalities, vertebral anomalies, and duodenal malrotation. Her family history was unremarkable. On the physical exam, she exhibited dysmorphic features. She had hypotonia but preserved reflexes and no lateralizing weakness. Persistent thrombocytopenia was noted right after. However, she did not experience any significant bleeding episodes. Chromosomal microarray detected an 11.06 MB terminal deletion of chromosome 11q24.1 to q25, consistent with the diagnosis of Jacobsen syndrome. Brain magnetic resonance imaging on day 14 of life showed mild ventriculomegaly with scattered areas of subtle supratentorial white matter abnormality. A follow-up MRI at 1 year of age showed diffusely increased T2 flare signal intensity involving almost the entire supratentorial white matter. Brain magnetic resonance spectroscopy performed at this time showed elevated choline and decreased N-acetyl aspartic acid peaks without any lactate peak. A repeat MRI at 2 years of age showed some interval improvement in extensive white matter abnormality, particularly in the posterior quadrant, suggesting demyelination process resembling leukoencephalopathy. No signs of old hemorrhage were seen on susceptibility-weighted imaging. Another MRI at 3 years of age showed continued interval improvement in white matter signal abnormalities with interval development of diffuse perivascular space enlargement bilaterally. Central nervous system involvement is seen in the majority of Jacobsen syndrome cases, often manifested as developmental delay and including MRI abnormalities such as cerebral atrophy and leukoencephalopathy. There were also cases with brain hemorrhages associated with severe thrombocytopenia. Even though our patient has low platelet count during infancy, her susceptibility-weighted imaging was negative for brain hemorrhages. There were many studies about patients with JBS and associated hematological and immunologic disorders, but there have been only a few studies that have shown signal abnormalities in the white matter. The patient's MRI shows diffuse supratentorial periventricular deep white matter signal hyperintensities with involvement of subcortical U fibers, mostly in posterior regions such as occipital lobe, and elevated choline and decreased N-acetyl aspartic acid, suggesting demyelination. It appears that diffuse white matter demyelination mimicking leukoencephalopathy can be one of the unique MRI features of Jacobsen syndrome associated with chromosome 11q deletion. The patient's diffuse bilateral supratentorial white matter abnormalities appear to be gradually improving over the years with development of prominent perivascular space. Although there is a precise idiopathic genetic relationship between white matter abnormalities, Jacobsen syndrome's evolution and neurocognitive development is presently not completely understood. These white matter changes may represent a possible biomarker surrogate and help in better understanding the neurological and cognitive development, as well as possible prognostication.